We'll move on to the next talk. This is by David Kerr from IBM, and he's going to talk about Watson Oncology. I presume it's all got to do with computing, so maybe I'm wrong.
Regie, das ist das Falsche. Es ist
searching for my presentation. So as we wait for the chart deck to come up, IBM has does a lot of research. We do a lot of research into there we go, a lot of research into computational biology and things like that. One of the areas of research that we embarked on over the last several years was, can you apply computers to reason and think in a manner that a human would think, or approach problems in a manner that a human would approach problems. And now we're not representing that computers can replace the human brain, but we are representing that computers can be a very valuable tool to help the human brain, human intellect make decisions. We demonstrated this a few years ago on a television quiz show in the United States called Jeopardy, which is a quiz show of general knowledge, and the information and the answers to the questions posed in that quiz show could only really be correctly answered if you had a pretty deep understanding of general knowledge. It could be anything. The answer could be found in the Bible, could be found in Shakespeare, it could have been found in yesterday's newspaper. Right? And so Watson was the computer system that we developed to tackle that problem. We demonstrated with some success that we could do that, and then we looked for other applications of that technology. And so one of those applications that sort of filtered to the top pretty quickly was medicine. As we looked at medicine, we sought some partners that we could work with to help us understand the challenge that physicians go through as they deal with patients every day, dealing with the complexity of each individual patient and the amount of knowledge that exists about individual conditions that a patient may suffer from. We quickly partnered with Memorial Sloan Kettering Cancer Center, which is a renowned cancer center in New York, and we focused our research and development activities around cancer diseases. We started out with a very focused approach looking at lung cancer and breast cancer. And we have since sort of expanded beyond that. And our partnerships with institutions have also grown, so we no longer just partner with Memorial Sloan Kettering, we have relationships with other institutes, like, for example, MD Anderson in Houston in Texas. Now, the problem that we were trying to tackle is the complexity of the decisions that physicians have to make. So the physician has to make a decision, the patient is sitting in front of that physician, and the physician has at his disposal his knowledge, what he has been taught, what he has learned, the references that he has been reading, the clinical trials that have been published. He also has available to him the individual patient's file, what is known about that patient, what tests or imaging have they undertaken, what X-rays or MRIs, what are the latest drugs that have been developed and that are available to consider, as well as other treatment options like radiotherapy or surgery, and the available laboratory tests that could be performed, or pathology tests that could be performed on the individual. And of course, he has colleagues that he can consult. Now, the challenge that physician is facing is we have an exponentially growing volume of knowledge. Right? So an individual textbook or magazine or a journal publication has been replaced with the ability to search on vast databases And that knowledge is expanding very rapidly. Just in the last 5 years, the volume of medical knowledge has doubled just in publications. The individual patient is being presented with a file. If it comes on paper, I mean, the physician at MSK brought into one of our meetings one day a file this thick, right, 4 inches thick, that had contained all the information about a patient that had just been referred to him. How can they deal with that? Electronic medical records are starting to take hold. It's not universal yet, but those records are allowing us to collect in a digital form all the information that's known about a patient. Within those records, however, you'll find there's contradictions. You'll find there's multiple tests have been run with different results. How do you make sense of that? Imaging has advanced a great deal. We have MRI, we have high resolution, we have CT scans, we've got traditional X-rays. The biotech industry, the genomics industry is doing a lot of research. We're discovering that genomics plays a much greater role in individual diseases, particularly in the field of cancers. We try and understand those with profiling them, with graphing them. If you are diagnosed with a cancer today, you're likely to have some sort of genomic testing performed. It may not be a whole genome sequence. In some institutions, they've sort of narrowed it down. In MSK, they've narrowed it to about 350 specific known genomic mutations that they will test for and look for specific indicators that might indicate what they could consider. And of course, your one colleague is now many colleagues with many specializations, and there's many places for you to go and seek second opinions from. And this is true not just for physicians, it's true for patients as well. Patients are turning to resources on the internet, patients like me and other resources, and they're often coming into a physician's office armed with the latest that they have read themselves from the internet. So as we think about that, there is an opportunity here for a cognitive solution, right? A system that can help both the physician and the patient make sense of all that information that is out there. Information of variant form, information from various sources, and growing at a very rapid pace. The question at hand really is, what is the correct treatment option for this patient at this time, given what we know about the patient, given what we know about the disease that this patient has been diagnosed with, and the latest available research and available therapies to consider. And this is the challenge that IBM, together with our colleagues and physicians at Memorial Sloan Kettering, undertook to solve, to put a system in place that physicians, in partnership with their patients and their institutions and all the knowledge around them, could use to help that decision process. So I have a demonstration of the system we have built. Before we go into that demonstration, let me just talk you through what we're about to see. Watson is sitting at the center. Watson actually runs in our IBM laboratory right now. What I'm going to show you are some screenshots that we've captured from a real session. And the information, the patient case about this was provided to us by our colleagues at Memorial Sloan Kettering, having been appropriately anonymized. And we're going to take that patient's record, which we'll illustrate this to you. It's a lot of plain text, natural language text. And we're going to examine that, and Watson's going to try and see what it can understand about that patient. So we're going to start by looking at the patient's record and understanding what's important within that patient record that a physician and patient need to consider. We're going to take those discrete pieces of information, and then we're going to look for appropriate treatment options based upon that knowledge about the patient. And the way we're going to look for those is we're going to look at a couple of sources. One is we're going to consider standard therapies. These would be therapies that are codified in guidelines. We illustrate here the National Comprehensive Cancer Network guidelines that are used in the United States. Another source would be clinical trials. So the clinical trial database that represents all available trials that could be considered for an individual patient. And we'll, from that, build a list of potential treatment options. And there may be many dozen different options to consider. And the next question then, of course, is which one is the right one, or which couple are the right couple. And the way we do that is we look at Watson's knowledge base. Now, the knowledge base for Watson has evolved considerably since the television quiz show. And so, we threw out the works of Shakespeare and stuff like that. We don't need that to help us make a decision. But we do need clinical journals. We do need clinical trials. We do need FDA labels. We do need the information about drug interactions. We need the expertise of physicians. How do physicians typically treat this patient? And we get that through our colleagues at Memorial Sloan Kettering to help us. We look at that knowledge base. We look for evidence that would support the selection of one particular treatment option over another, and we rank that using Watson's algorithms that Watson has been taught. Watson, as you've probably heard, is a learning system, and the way we teach Watson and train Watson is by giving it many patient cases over time. So we've given it well over 2,000 to 3,000 cases just in the field of lung cancer, for example. We look at the results Watson presents for each one, and we ask our physician colleagues, did Watson get it right or did Watson get it wrong? Where Watson got it wrong, we ask our colleagues what would we need to change, what did we miss, was it a patient attribute, was it lack of evidence, how do we fill that out? And so Watson then uses what it's learned to produce our proposed treatment option. So what I've taken is some screenshots, runs on an iPad connected to a back-end server. We're going to see an illustration of a 65-year-old female. She's been diagnosed with stage 1 breast cancer, and she's got an appointment with her physician. Oops. Go back, go forward. Okay, so she has an appointment. Let's go back one page. She has an appointment with her physician, and he's going to log into this system, and the physician is going to be presented on his tablet with a list of those patients that he is going to see today. And Jane Smith is the one, so he's going to select Jane Smith, and the first thing that Watson's going to do is read from the medical record the information, and that comes in, as I said earlier, largely as plain text. This has got the notes from previous consultations. This is just an illustrative one. In real life, as I said, it's often far more complicated. And then Watson is going to read that record. It's got laboratory results in it. It's got pathology reports in it, maybe the results of surgery, from notes from a surgeon, and then compares that against all the knowledge base it has, and it comes back with a result. What Watson has, and for some reason some of the graphic elements are not coming up here, but what Watson has found is what it's calling its critical attributes, which are shown on the left here. And as it scrolled down, it showed what it found, and then it showed that it is missing some information. And so the surgery has been performed on this patient, and yet there was no information in the medical record about the margins, had the disease spread beyond the actual physical tumour. However, Watson found a statement in there that said the surgical margins were free of carcinoma. Watson assumed that this meant that margins were negative, but it wasn't 100% confident, so it asked for the physician to confirm that. The other piece of information that was missing was the ECOG status, so the physician will verify that, and the other one is the ECOG status, which we will indicate as fully ambulatory. And then we can ask Watson again, and now Watson is going to come back with what it believes is its recommended treatment options. and we're going to see some indications here, chemotherapy and refer to radiation therapy, or just refer to radiation therapy. Now, as on the right-hand section here, you can see standard therapies. You may also have clinical trials presented to you. These would generally be ranked. They would be ranked as sort of color-coded green, orange, red. What we see in this example here is nothing's highlighted as green. We have some in orange here, which could be considered. And on the left-hand side, Watson has listed some additional pieces of information that Watson believed would be helpful in making the recommendation. And this is information that Watson had not found from the record. So it is recommending an oncotype diagnostic test, and which we can fill in, and we're going to indicate it's high. And in changing that value, Watson is then letting us go back and ask again how that would change the recommendations. So what's happened here is that we have a recommended one. I'll just click on it. I'll clean that up, hopefully. And so we now have a recommended series of chemotherapy followed by radiation therapy and then endocrine therapy for this individual patient. Now, anytime you see a little icon that represents the Watson logo, you can click on it, and Watson will return what information it found to support or refute the individual recommendation. Once again, we have a number of different choices here. There's different chemotherapy choices, and they are sort of ranked based upon Watson's understanding of the individual's patients and when those particular drugs would be considered effective. Click on the particular treatment, and we have some of the supporting evidence. Now, this can come from all sorts of places. We've licensed content from the major publishers, journal publishers. We also have, of course, the PubMed content available to us. In addition to the rationale, we have information about how you would administer the treatment. This is information from Memorial Sloan Kettering. Other institutions may have their own way of administering it. But one of the tools here, one of the things that's valuable here is at the top, when you had the timeline, was an indication that this would likely be a therapeutic regime that would last a couple of years. You're starting with chemotherapy and radiation therapy, get done with pretty quickly, and then you're on a drug and endocrine therapy for a couple of years. We get warnings and toxicities come from the FDA label, and then you can export this information either back into the medical record, or you could print it out with some patient information that the patient could then take home. This is an illustration of what would get printed out in this particular case. In the United States, there's a process required to get pre-authorization before you can undertake treatment, and so we'll provide that capability as well. So that was a quick demonstration of the system we have built. I just used breast cancer as one example, but we have other cancers covered as well. And just to close, I just wanted to sort of highlight some of the differences between what I illustrated today and what you may typically find in a decision support system. Many decision support systems are sort of coded with fixed rules. If you fit within those rules, you follow down a path and you get a specific recommendation. Indeed, the NCCN guidelines themselves have that. What differentiates Watson is Watson's ability to be taught and learn from example, and therefore understand the nuances for individual patient cases which maybe not follow so neatly the predefined rules in a rules-based system. Watson uses that to generate many different hypotheses of what could be considered. So rather than just having one answer, we have the opportunity to consider many different answers, and indeed we can present, as you saw in the illustration here, the alternatives for a physician to consider, because in many cases there may not be a clear-cut treatment regime that would be most appropriate for the patient. And so it's very valuable to present to the physician and the patient the alternatives and the information and the rationale that support each alternatives. And so with that, at precisely 0, I will point out, I will conclude my presentation this morning. Thank you.
The session's open for questions.
Very nice presentation. One of the questions I have is, are you able to take a picture of the patient every single time? Because, you know, you have a feedback part where the physicians are giving the system feedback, but a lot of the feedback that the physician gets is seeing how that patient is walking up to them, what they look like, how they've changed over time. Do you have an aspect in this, because as you know, a good physician usually takes 20 years to get to that point. The informational content, I think, is fabulous, but have you been able to add that type of information in and use that, or is it plug-inable against your system?
So Watson itself is doing no image processing or image analytics. So even in the case of pathology or radiology, Watson's not analyzing the images. It is looking at the notes that were written by the radiologist or the pathologist. In the case of a patient walking into a physician's office, it would be looking at the physician's notes as the physician recorded how that patient appeared. Now, could such an image analytic capability be provided as a plug-in? Certainly, right? So that capability is certainly there, but it is not something that we have right now.
Wonderful. Something is basically missing. The human factor. The cure of the patient depends on his faith to the doctor. This faith to the doctor is enhanced by his manners, the bedside manners, his knowledge, his experience, the availability of the consilium of the professors. Are we driving toward the humanizing medicine?
You are very, very correct. And in fact, the human factors of how Watson would be used by physicians was a very important design consideration. One of the things we learned as we talked to physicians, you know, decision support systems have not been as widely adopted as many of us would like to think. And a lot of that has got to do with the awkwardness of using them with a patient. So I illustrated an iPad-based system prototype here, and much of that was based upon physicians telling us that they were very comfortable sitting next to a patient with an iPad and illustrating to the patient with that. But you're absolutely right, nothing is going to replace the human factors in our patient-physician relationship, and it is not our desire or intention to replace that very important piece of the patient relationship.
I have a question. So related to the topic, I'm sure Watson is very well behaved and well mannered, but the question is, if you have a patient that sort of doesn't fit the standard therapy regimen of approved drugs, and most of the example you showed is that sort of the typical cytotoxics, for example, you know, in the day of genomics, and you know, where mutations are important, and you know, not many drugs are approved based on mutations yet, but that'll come soon. There's many in clinical trials. So how does that algorithm work, or how is that, or is that built into the Watson system?
So every physician we've talked to has emphasized the importance of clinical trials and considering their patient for non-standard treatments. And so we have built into the system, I scanned over it very quickly, but there was a clinical trial button there, and so we do load into the system knowledge about available clinical trials. Now, if there is something that is not documented as a formal clinical trial, then the system would not know about it.
Thank you for the presentation. So I also miss a little bit the personal part, because you have, Watson is able to read the physician notes. Perhaps the physician's notes are incorrect because the physician doesn't know so much, therefore you need Watson. So I think that this kind of help would be really useful if you would start from the molecular information of the patient, from the genetic information of the cancer, and you would try to match the appropriate therapy based on not a physician believe with his limited experience, because this is what you want to solve, a physician limited experience, but you would start with the molecular knowledge or molecular information of the patient's cancer, and then you would try to match clinical trials or available therapies.
So I want to make two comments there. One is that we rely upon what's recorded in the medical record to make to do the analysis. We do find contradictions in medical records. We've done a case with a hospital in Texas. It was Seton in Austin, where they looked at smoking and how individuals, whether they were recorded as a smoker. And we found lots of discrepancies in the medical record about whether that individual was correctly identified as a smoker or not, using some of Watson's natural language technology. Now in genomics, particularly the field of cancer, is very much switching towards the molecular pathology of individual tumours and the individual concerned. Watson does take that into consideration, but it has to be recorded in the medical record. The particular mutations need to be in the literature somewhere, right? So if Watson finds commentary related to breast cancer and a particular genetic mutation, HER, whatever, HER2, and if it doesn't find anything in the medical record that says anything about that, Watson can highlight to the physician that, there's a body of evidence that talks about this molecular evidence for this particular disease. There's no mention of it in the record. Should there be something, should there be a test performed? And lastly, I would just point out that, within Watson, we have another project which we've called Watson Genomics, and we've partnered with the New York Genome Center in New York and in the USA to do a whole genome sequencing. So they're providing whole genomes for us. We are taking the sequences of those genomes, and we're looking out into the literature to see what can be found that might indicate an actionable therapy based upon that. So absolutely agree with what you're saying, and we are in the process of figuring out how we can provide assistive tools for that.
A related but slightly different question. So if you're trying to make treatment decisions and use Watson to help with that, is IBM or the Watson group willing to take the litigation risk to make the wrong decision? Any thoughts on that?
The safest thing for me to say would be no comment. Seriously, it is a complex and difficult topic that is, a lot of our legal minds and IBM are applying their thoughts to.
There's a couple of questions at the back. Terry, you were first. Go ahead.
So as we get more and more into the big data, on all the omics data in personalized medicine, the big challenge, of course, as you I'm sure perfectly aware, is how to interpret that. Is Watson going to be able to handle the kinds of huge data that will be coming into the system as we get into all of these omics assays, and be able to assist or learn how to interpret that huge mass of data?
So Watson is many things. What I illustrated this morning was just one part of Watson. Big data and streaming data, whether it's coming off of medical device monitoring devices or whatever. We have technologies that understand and attempt to interpret that, give early notification of potential problems for the patient. So, I mean, the short answer is yes, but really it's a far longer, more complex answer because there are different analytic technologies being applied to that. And the Watson cognitive piece may not do the raw analytics and the big data, but it will take the output of something that does analyze those vast volumes of data and then take that, the sort of summated version of that and use that in its decision support, decision analytics component.
Shezi?
Thank you. I have two related questions. What about the aspect of patient quality of life? And the second one, do you have anything that Watson will deal with nutrition aspect?
So that's another dynamic that has always been brought up as we talk to physicians, is the quality of life. And in fact, one of the earlier examples, not this particular example, but one of the earlier examples that we used when we first entered this project was a younger female individual with lung cancer who was concerned about hair loss. And so there was the choice of treatment took into consideration patient-indicated preferences, whether it is hair loss, nausea, neuropathy, things like that. So quality of life, and then as you get towards end of life, that's a very politically dangerous area in the United States. When you come to end of life care, and at what point do you decide it's not worth another round of chemotherapy or whatever? We are very sensitive not to get into that debate. We think that should be left to the physician and the individual patient to really consider, the end of life treatment options and palliative care.
There's a question from Frank, but I warn you, I think he's going to ask you, are you regulating this as a device?
No, I'm not going to ask this, but what I'm going to say is this: garbage in is garbage out. And what is your perspective on data quality and maybe data standards? Because that's obviously a big issue also for regulators.
Yeah. In fact, that's one of the biggest challenges with Watson. The quality of the data input. So one big challenge we have is a lot of, while we talk about electronic medical records, much of those medical records today are scanned documents. Printed documents are made printed, but the OCR, the optical character recognition capability, may not be of a high enough fidelity. And it's a particular problem with faxed documents, and a lot of documents sent around between physicians are faxed. And so that is why, one of the steps where I illustrated here was the first step for Watson was for Watson to say, here's what I found, and to give the physician an opportunity to correct or verify what Watson found was correct. Because if there's a inaccurately interpreted field in there, then garbage in, garbage out. So we are very sensitive to that. There are some things that we just have chosen not to deal with when they come in a faxed form or form. We explicitly ask the physician to select from an entry field or whatever, like we illustrated up here. It's a very challenging problem.
Last question, then we have to move on.
How much peer review have you done on the use of it, where you, would raise these recommendations with experienced professionals and say, how do you rate that?
Right. So for peer review, the stage we're at right now is we're just starting to launch it out to a wider audience to get their review and feedback. About a year ago, we had selected 3 or 4 regional oncology practices in the US and the Northeast, and we provided them with an early system and asked them to kick the tires. That gave us some good feedback as to how well we were progressing. We then sort of stopped that for a bit. We went and sort of rejigged, not rejigged, but we continued development based upon some of the feedback we received, and we're now going out to a more wider audience. So we will enter into a phase in computer science. We call it beta testing, beta versions. I'm sure you see that yourself, all over. We will enter a beta phase where we will seek that input. We're looking for both a clinical point of view with respect to the treatments being recommended, and we're also looking for ease of use, how easy is the system to use, and its applicability in a context where you're actually providing real medicine. Throughout this process, we have reviews within the systems that we are working with, so Memorial Sloan Kettering and MD Anderson being the two large systems we're working with. And we're just, as I mentioned, we're just about to extend out beyond that. Thank you.
Let's thank the speaker again.